Hello, my name is Dr. Susan Carroll. I'm a psychologist at King's College London, and I also happen to have MRKH myself. I'm going to be sharing with you some of the key findings from our recent paper, which looked at illness representations, self-concept, and psychological adjustment in MRKH. MRKH affects around 1 in every 5,000 women, and it means being born with an absent or underdeveloped uterus, cervix, and vagina. It can bring many challenges for patients, like being diagnosed in adolescence when young people are exploring their identity and sexuality, deciding about or going through vaginal lengthening treatment, infertility, navigating intimate relationships, knowing how to talk about an intimate part of the body, and deciding when or who to tell about the diagnosis. So we wanted to better understand psychological adjustment and factors associated with adjustment outcomes like distress. So 263 people completed online questionnaires about demographic and clinical factors, how they perceived and understood MRKH, how MRKH fit within their identity or self-concept, and how these factors related to distress. So we found that 54% of people in our sample reported significant psychological distress. And to put that in context, in population-based studies using the same measure that we did, about 20% of women report significant psychological distress. So distress is clearly common and problematic in MRKH, and we need to be providing opportunities for psychological and social support in clinical practice. When we looked at factors associated with distress, we found that having a lower perceived coherence or poor understanding of MRKH was associated with higher distress. So we need to check patients' understanding of MRKH and provide opportunities to improve understanding when needed. It's also important that we educate non-specialist healthcare providers about MRKH so that they can pass on accurate information to their patients. We found that identity was important in that people who described higher engulfment or feeling that their identity was consumed by MRKH had higher distress, and those who reported higher enrichment or positive changes to their identity because of MRKH had lower distress. So in addition to focusing on medical interventions to create a vagina and exploring options to have children, we need to work with people with MRKH to help them to fit it into their identity and sense of self in a way that is comfortable for them. And going forward, future work should focus on psychological interventions led by psychologists or peers to see what will be most effective in helping people psychologically to adjust to the diagnosis. Thank you very much. Please do get in touch if you have any questions.